This recorded lecture will go over Chapter 23, The Child with a Sensory or Neurological Condition. An acute infection of the external ear canal is called otitis externa and is often referred to as swimmer's ear because prolonged exposure to moisture is often the precipitating factor. Pain and tenderness on manipulating the pinna or tragus of the ear are specific signs of this type of infection. Irrigation and topical antibiotics or antivirals are the treatments of choice. Otitis media is an inflammation of the middle ear. An infection of the throat could easily spread to the middle ear and lead to mastoiditis. Otitis media often occurs after an upper respiratory tract infection and usually affects children between 6 and 24 months of age and those in early childhood. Infants are more prone to middle ear infections than older children and adults because their eustachian tubes are shorter, wider, and straighter. The signs and symptoms of OM are pain in the ear, which is often very severe, irritability and diminished hearing, fever, which could be as high as 104 degrees Fahrenheit, headache, vomiting, diarrhea, and febrile seizures. Visualization of the tympanic membrane via otoscope will show a reddened and bulging membrane. OM is considered chronic if the condition persists for more than 3 months. The first-line antimicrobial medication prescribed is oral amoxicillin, which is given for 10 days, with a follow-up scheduled after 2 weeks. Surgical intervention may be necessary when medical treatment is unsuccessful. A maryngotomy is the incision of the tympanic membrane to relieve pressure and prevent a tear by spontaneous rupture. A tympanic membrane button may be inserted if the condition becomes chronic, lasts more than 3 months, or causes hearing difficulties that impair school performance. Antipyretics can be given to reduce fever, and a warm compress can be applied locally for comfort. Congenital hearing loss in the newborn may be hereditary or may result from in utero infection, a low birth weight, prolonged resuscitative measures, or specific anomalies or syndromes. Sensorineural hearing loss occurs when the hair cells along the cochlea and acoustic nerve may be damaged, which could occur from exposure to environmental toxins, genetic anomalies, or exposure to loud noise. Conductive hearing loss occurs when the tympanic membrane prevents sound from entering the middle ear. Hearing loss will be expressed in terms of decibels, which are units of loudness and are the basis for rating the severity of hearing loss. The American Academy of Pediatrics recommends a goal of universal detection of hearing impairment in infants before 3 months of age, with intervention started no later than 6 months of age to minimize problems with growth and development. A tuning fork can be used to evaluate for air conduction or bone conduction. These tests do require the child to be cooperative and able to communicate what is heard and felt. A diagnosis of hearing loss can be confirmed by visual reinforcement audiometry, which identifies sensitivity to sounds in young infants. The nurse should be aware of symptoms of deafness in the child. Visual aids, writing, or drawing can be used to enhance communication. Home care of the hearing impaired child should include speech therapy. Barotrauma occurs when there is a change in atmospheric pressure between the internal body system and the surrounding environment. An example of barotrauma would be the painful obstruction of auditory tubes when in a pressurized cabin of an airplane. The newborn's sight is not mature, but the newborn can see. By 2 to 4 months, infants can move their eyes to follow people or objects that may be 6 feet away. By 4 to 5 months, their eyes are open most of the day, and tears when the infant cries can be seen to overflow on the face. Depth perception is not developed until 9 months of age. The AAP recommends that all children undergo preschool visual screening during well-child visits between 2 and 3 years of age. Picture cards can be useful for children who do not know letters. Visual acuity can be tested by 2.5 to 3 years of age. Amblyopia is a reduction or loss of vision that usually occurs in children who strongly favor one eye. When abnormal binocular interaction occurs, the prognosis will depend on how long the eye has been affected and the age of the child when treatment begins. The earlier the treatment is given, the better the results. There are various types of amblyopia. Early detection and prompt treatment are essential. Treatment consists of eyeglasses for significant refractive errors like hyperopia or myopia and patching of the good eye. Strabismus, also known as a squint, is a condition in which the child is not able to direct both eyes toward the same object. There is a lack of coordination between the eye muscles that direct movement of the eye. The brain will disable one eye to provide a clear image. Normal binocular vision is the goal and must be accomplished by intervening early, before the eye matures. There are several types of strabismus. Eye exercises and glasses are effective ways of treating this condition medically. If they do not help, surgery can be considered. Eye dressings must be kept at a minimum, and elbow restraints may be sufficient to keep a child from touching the dressings. Conjunctivitis is an inflammation of the conjunctiva, which is the mucous membrane that lines the eyelids. A wide range of bacterial and viral agents, allergens, irritants, toxins, and systemic diseases can cause conjunctivitis. The acute infectious form is commonly referred to as pink eye. In general, the common forms of conjunctivitis will respond to warm compresses and topical antibiotic eye drops or eye ointments. On page 545, in image figure 23.5, you can see and read about the symptoms of conjunctivitis. Hyphema is the presence of blood in the anterior chamber of the eye. This is one of the most common ocular injuries. It can occur from either a blunt or perforating injury. Treatment will include bed rest and topical medication. Retinoblastoma is a malignant tumor of the retina of the eye. A yellowish-white reflex is seen in the pupil because of a tumor behind the lens. This can be accompanied by a loss of vision, strabismus, hyphema, and in advanced tumors, pain. The standard treatment of unilateral disease is enucleation of the eye if there is no possibility of saving the vision. An eye prosthesis can be fitted when the eye socket has healed. Skull X-ray films, EEG, CT, MRI, electromyography, and other methods like neurological checks can all detect CNS dysfunction. A decreased level of functiousness in the ill child could be an indication of a neurological problem. On page 546 within box 23.1, you can read about causes of altered levels of consciousness. Ray's syndrome is an acute, non-inflammatory encephalopathy and hepatopathy that follows a viral infection in children. Toxic levels of ammonia will cause cerebral manifestations, which result in neurological changes like altered behavior, altered level of consciousness, seizures, and coma. In children, the sudden onset of effortless vomiting and altered behavior or an altered level of consciousness after a viral illness is a characteristic of Ray's syndrome. Early treatment can result in recovery with some neuropsychological defects. The goals of treatment include reducing ICP and maintaining a patent airway, cerebral oxygenation, and fluid and electrolyte balance. Sepsis is the systemic response to infection with bacteria. It can also result from viral and fungal infections. Untreated sepsis results in septic shock, multi-organ dysfunction syndrome, and death. Manifestations of sepsis include fever, chills, tachypnea, tachycardia, and neurological signs like lethargy. Hypotension is an ominous sign that may indicate that the body is unable to compensate adequately, and cardiorespiratory arrest is about to occur. Nursing responsibilities include monitoring neurological status and vital signs, observing for shock, and maintaining strict standard and expanded precautions. Meningitis is an inflammation of the meninges. Bacterial meningitis is often referred to as purulent because a thick exudate will surround the meninges and adjacent structures. The symptoms of purulent meningitis result mainly from intracranial irritation. Severe headache, drowsiness, delirium, irritability, restlessness, fever, vomiting, and stiffness of the neck are other significant symptoms. Seizures are common. At the first indication of meningitis, the healthcare provider will perform a spinal tap to obtain a specimen of CSF for laboratory testing. The spinal fluid will become cloudy. The child is placed in isolation until 24 hours after antibiotic therapy has been initiated. Antibiotics are typically administered for a minimum of 10 to 21 days. Nursing responsibilities include performing frequent neurological checks and maintaining an accurate recording of the child's vital signs and intake and output. The nurse should also organize care so that the child is disturbed as little as possible. Frequent monitoring of the child's vital signs is necessary. Intake and output should be carefully observed and recorded. The nurse continues to monitor the child's neurological status and record and report findings like weakness of the limbs, speech difficulties, mental confusion, and behavior problems. Encephalitis is an inflammation of the brain. The history is that of a headache, followed by drowsiness that may proceed to a coma. Seizures are seen, particularly in infants. Fever, cramps, abdominal pain, vomiting, stiff neck, delirium, muscle twitching, and abnormal eye movements are other manifestations of the disease. The treatment is supportive and aimed at providing relief from specific symptoms. Sedatives and antipyretics can be prescribed. Seizure precautions must be taken. Brain tumors are the second most common type of neoplasm in children. The majority of childhood tumors occur in the lower part of the brain. They occur most commonly in school-age children. The signs and symptoms will be directly related to the location and size of the tumor. Most tumors create increased ICP with the hallmark symptoms of headache, vomiting, drowsiness, and seizures. Clinical manifestations, lab tests, CT, MRI, and EEG will confirm the diagnosis. Radiotherapy, chemotherapy, or surgery may be indicated. Radiation treatment may be prescribed. The radiologist outlines the areas to be treated on the child's head, and these marks should not be washed off. Seizures are the most commonly observed type of neurological dysfunction in children. The etiology can vary, and you can read more about this in box 23.2 on page 552. A tonic movement is a stiffening or contraction of muscles. A clonic movement is an alternating contraction and relaxation of the muscles. Febrile seizures are a transient condition common in children between 6 months and 5 years of age. The seizure will occur in response to a rapid rise in temperature, often above 102 degrees Fahrenheit. Parents should be reassured that this condition is typically self-limiting. Epilepsy is characterized by recurrent paroxysmal attacks of unconsciousness or impaired consciousness that may be followed by contraction and relaxation, resulting in alternating tonic and clonic movements of the muscles or abnormal behavior. Table 23.2 on page 553 will describe the first aid response and nursing responsibilities during a seizure. Childhood epilepsy can be classified into partial seizures and generalized seizures. Initially, treatment is aimed at determining the type, site, or cause of the disorder. The EEG is also a valuable tool in diagnosing seizures. The duration of therapy will depend on the individual child. The goal is to control the seizures and minimize toxic effects of the medication. The medication is administered at the same time every day, generally with meals or at bedtime. Abrupt withdrawal of anticonvulsant medications is the most common cause of status epilepticus. On page 555 within table 23.3, you can read about properties of selected anticonvulsant drugs. The ketogenic diet is sometimes prescribed for children who do not respond well to anticonvulsant therapy. This diet is high in fats and low in carbohydrates, with adequate protein for growth. The diet produces ketoacidosis in the body, which appears to reduce convulsive episodes. Restriction of physical activity is not necessary, but adult supervision during swimming or bathing is advisable. A prolonged seizure that does not respond to treatment for 30 minutes or more is known as status epilepticus. This can result in brain hypoxia. Treatment includes managing the airway, providing oxygen, observing and documenting details of the seizure, and providing IV therapy. Diazepam, lorazepam, phenytoin, or phenobarbital drugs can be given IV. Benign paroxysmal vertigo is a condition that occurs in children less than 3 years of age, who often develop ataxia and fall. Nausea, vomiting, and complaints of motion sickness and migraine headache will follow. Night terrors can occur in children between 5 and 7 years of age. Breath holding can result in cyanosis or extreme pallor. Episodes of breath holding are most common between 2 to 5 years of age and are often the result of immaturity of the autonomic nervous system. Cough syncopes or paroxysmal coughing spells, usually at night, that result in a diminished cardiac output, cerebral hypoxia, and loss of consciousness. One type of sudden loss of consciousness is associated with vigorous exercise. It can be caused by a heart problem and reflected as a prolonged QT segment on an EKG. This can result in loss of consciousness and death. Rage attacks are sudden recurrent attacks of violent physical behavior. This condition is often mistaken for complex partial seizure epilepsy. Cerebral palsy is a term used to describe a group of non-progressive motor disorders caused by a lesion in the various motor centers of the developing fetal brain. On page 557 within table 23.4, you can read about the types of cerebral palsy. CP is not fatal in itself, but there currently is no cure. The symptoms of CP will vary with each child and can range from mild to severe. Diagnostic tests will include a metabolic and genetic testing and MRI. Early recognition is important for appropriate referrals. The goal of treatment for children with CP is to assist them in making the most of their assets and guide them in becoming well-adjusted adults, performing at their maximum ability. Pain management and medication for gastroesophageal reflux can be prescribed. Physical therapy is essential to prevent contractures and deformities. Parents should be informed of community resources available to them. Specific treatment will be highly individualized and depend on the severity of the disability. Good skin care is essential for the child with CP. The nurse should encourage the children to do as much as they can for themselves. Measures necessary to prevent contractures include frequent changes of position, the use of splints, and the performance of passive range of motion and stretching exercises. Feeding problems could lead to nutritional deficiencies. The physically challenged child will need opportunities to play alone and with other children. The requirements for good mental health in the physically challenged child do not differ from those of other children. When a child is diagnosed as intellectually impaired, it is important to correlate growth and development with mental functioning. Intellectual impairment or disability has been defined as a below average mental functioning or IQ below 70 and a deficit in adaptive behavior, conceptual skills, or social skills manifested during the developmental period. You can read a bit more about this on page 560 within box 23.4. You can also read about the elements involved in mental functioning on 560 in box 23.5. A diagnosis of intellectual disability is determined after a thorough study has been made. In certain cases of early recognition and intervention, the child may be classified as having a developmental delay before a diagnosis of cognitive impairment has been made. Other symptoms of intellectual impairment are associated with milestones of the growth process. The pediatric nurse must assist the parents to understand that providing experiences in which the child can be successful and concentrating on his or her strengths rather than weaknesses are the keys to helping a child who is developmentally different. An individualized plan of care with goals and objectives is vital to managing intellectually impaired children and helping their families. Nurses must be familiar with the resources to the community so that they can direct the family to them. Head injuries are the major cause of death and permanent injury in children older than 1 year of age. A concussion is a temporary disturbance of the brain that is typically followed by a period of unconsciousness. A skull fracture, brain concussion, contusion, or intracranial hemorrhage could occur at the time of injury. A child who sustains a mild bump to the head retains consciousness and does not vomit, therefore they can have a covered ice pack applied to the site. Confusion, cognitive changes, or amnesia after any head injury could indicate a concussion, even if consciousness has not been lost. Roughly shaking an infant could cause the brain to strike the inside of the skull, known as shaken baby syndrome. Teaching coping techniques to parents of children who cry inconsolably can prevent this type of injury. A child who has suffered a blow to the head should often be brought to the hospital for overnight observation to rule out or confirm the extent of injury. The child could experience all or some of the following symptoms: headache, drowsiness, blurred vision, vomiting, dyspnea. In severe cases, the child may be completely unconscious. Pathological posturing can be seen with severe brain injury. There are 4 components of cranial or neurological check: the level of consciousness, pupil and eye movement, vital signs, and motor activity. You can read more about this in depth on page 565 within box 23.6. The AVPU chart can be used as a guide to rapidly document the altered mental status of a child. A for awake and responsive, V responds to verbal stimuli, P responds only to painful stimuli, or U unresponsive. An increase in blood pressure and a decrease in pulse and respirations are evidence of increased ICP. The quality and strength of muscle tone will be observed in all 4 extremities. The face should be symmetrical. Abnormal posturing should be described and recorded. Nursing care includes examination of the wound swelling if a laceration of the head is present. The type and amount of drainage from the ears and nose should be recorded. Parents are instructed about any additional observations and follow-up care. Most children are advised to reduce cognitive activities after a concussion, including texting, cell phone use, TV, loud music, and computer use, with a gradual return to full activity. Following even a slight head injury, the child should be assessed before continuing in sports activities. Coaches are not qualified to assess head injuries, and a baseline function should be established before the child enters any contact sports activities. Near drowning is defined as survival beyond 24 hours after submersion. The priorities include immediate CPR and treatment of hypoxia, aspiration, and hypothermia. Submersion for more than 10 minutes with a failure to regain consciousness at the scene or within 24 hours is an ominous sign and is predictive of severe neurological deficits if the child survives.